Good evening, everybody, and thank you, Turkey, for having me here once again. I was here about a month back. Talked to David, and that was an amazing talk. And today my talk is not only on KLEX. I've been asked to talk a little bit on the MRS and few of the scanners over here. So the Shrink platform over here, I'll be talking a little bit on the MRS. The Atos is the femtosecond laser, and some of the treatments that the MRS and the femtosecond laser provides on the Shrink platform. So I am also a consultant and a KOL for the Shrink company. I was mainly for the Atos. The first femtosecond laser of the Shrink was in my clinic back in 2018 and 19. So let me tell you a little bit about myself. So I've done 2 clinical trials for Carl's eyes. That is the myopic as well as the hyperopic back in 2010 and 2014. One of our biggest problems with the smile problem was that treatments were not very up to the point where patients, you could not compare a smile with LASIK all the time. And things are very slow, things are not moving because the eye tracking was not sufficient enough. And so I moved into the Shrink platform. And in 2019, I got the first Atos. Now I have 2 clinics, one with an MRS, Prisumax, and an Atos, and the second clinic with only an Atos. I will tell you why. So since 1992, Shrink has developed tremendously the different lasers, especially in the excimer field. They have the 500, 750, and 1050. And on the femtosecond laser, we have the Atos. It was first called the Titan, and then it's called the Atos now. So what I'll be really talking about is a little bit on the femtosecond, which is called SmartSight and SmartSight Nova for lenticular extraction for myopia, myopic astigmatism for flaps, customized Shrink TheraCare, TransPRK, and Prisumax, mainly on the MRS platform. So these are the lasers now. You have Atos, Shrink MRS 1050, which is the fastest. Then you have 750 and 500. So many times you have to think that Shrink starts off where most of the lasers end, from 500, 750, and 1050. And we have the treatment plans over there, the treatment support. We have the ORK CAM, Prisumax module, PTK module, and the Shrink Foresight. So now Dr. Devgan has been talking about AI. I'll tell you where we have mastered it right now. And on the diagnostic, we have the Beramis, MS39, and the Cirrus. So they're all from CSO, but they're very different from a normal diagnostic device. They have different softwares that can be linked directly into the lasers. So again here, you have the MRS 500, 1050, 750. They are very, very fast, very accurate, very safe, very smooth, and with excellent outcomes. I wonder how many people are using the MRS over here. Anybody using the MRS over here? Yes, and anybody using the Visumax? And anybody using the Atos over there? Because we know there are 5 Atos now in Turkey already. Okay, so now the MRS is like an amazing, amazing laser. Now I want to talk a little bit on the eye tracking. So let's go to this. I want you to only remember that slide over there, the latent free eye tracking. Let's go to the next slide. If you look at that, you have the first eye tracking over here. You say it has a 7-dimension eye tracking system. Is the horizontal displacement. So what is a horizontal? Look at my hand. So a horizontal displacement is, if your eye is horizontally displaced, the laser will track it. The second one is a vertical displacement. So this is a vertical displacement. Then you have a horizontal rolling. The eye is rolling like this. You have a horizontal rolling, vertical rolling, cyclotorsion, and you have on the axis, if the patient is pressing or trying to get up on this axis, and the 7th dimension is the laser already knows where your next eye movement will be. It already knows. So before the eye moves, the laser is ready to fire. So it is so very accurate and precise. It's amazing, amazing laser. And if you look at the ablation, 80% of the ablation is on high fluence and 20% is on low fluence. Automatically it shifts because 1050 is a very high frequency laser. It can actually, if you think of it, you could burn the cornea, but it's actually not because it moves from high to low fluence. So it has an excellent thermal control. And looking at all the things that we have now, the performance of the spectrum for the cam, this is what you have is the shrink cam software. What you have is the ORK and the PresVmax, where you can do aspheric treatments for PRK, trans-PRK, LASIK, LASIK and femtoLASIK, which can be aberration-free, corneal wavefront treatments or ocular wavefront treatments, depending on the patient, which can be refractive. And then you have PresVmax treatments, which is biospheric, mainly LASIK or trans-PRK for presbyopic treatments. So we'll be talking a little bit on that too. And then you have PTK cam, mainly refractive neutral, keratoplasty, stromal or transepithelial, round, elliptical, or any shape that you want, mainly for the therapeutic treatment. So this is your treatment for your trans-PRK. So this is, I really love, most of my, 60% of my treatments in my clinic is SmartSight Nova. Nova is a new lenticular procedure where it is, I'll be talking about that. And then the 40% of them are trans-PRK. If the scans are good, SmartSight. If the scans are not good, I go for trans-PRK. So what trans-PRK actually does, in one shot, in 30 seconds, you can just press a button and it starts treating. So it can be aberration-free or corneal wavefront-free, like, whatever. What it does, the first treatment it does is the refractive treatment. So whatever power it has, -2, it treats -2 first. So it does not treat the epithelium. Then, because it could be anything there, it could be over dehydrated or hydrated or anything irregular over there in the cornea, is taken care. First treatment is the refractive, and then you have the epithelial treatment. And then also you have a little bit of wavefront treatment. So it's basically two main steps, and you have a small third step you will know with the sound of it. So it is totally different. You don't have to stop. You don't have to retake anything from, you don't have to take softwares again and again. So in one shot, one button, 30 seconds, it's an amazingly smooth treatment. Trans-PRK can also be done by femtosecond laser, which we'll talk to you with the Atos. So with all these, you can see it in our peer-reviewed publication for the MRS as well as the Atos. So I am mainly a KOL for the Atos actually. Let me talk to you. So on these, we have amazing scanners. We have the MS39, an OCT, a Paramis, an aberrometer, and a Cirrus Plus. So these devices can be directly linked to any of the devices. So you can take a scan and you can put it into the MRS or you can put it into the Atos. And the lasers, both the femtosecond laser as well as the excimer laser, can recognize, can do the amount of cyclotorsion that's happening, can measure the average, and can treat exactly right through the scanner. You don't need anything in between. You don't need an aberrometer, or you don't need a biometer, or you don't need any other thing. It is directly from one scan into the laser, and both the lasers are so smart, it can treat exactly, analyze everything. So we have the MS39. It is a 3.6 micron axial resolution with, it is an amazing OCT. You can see everything. You can see from the epithelial, the 3D epithelial map, the stroma, the Bowman's, everything right with the posterior bone decay, the keratometry, as well as the Gaussian curvature in this. It is very good for analysis, and you can also use it for treatments. So I had the MS39, I think one of the first MS39 along with Professor Dan Weinstein. So we've been using a lot of AI, in especially a program called Foresight, to develop all of these lasers, all of these scanners. So some of the pictures over here, you can see they're amazingly good pictures, and you can see an ICL. And you can also have a flattened version of this. So when you see a flattened, you can see the Bowman's membrane, you can see the posterior elevations. And for the aberrometer, there is a pyramid sensor design with 45,000 measuring points, real-time aberrometer with plastro topographer with more than 5,500 points to measure. So I'll just be rushing through all these because I'll be talking mainly on the femtosecond. So let me skip this slide because it's quite a long slide. Now what I want you to look at this is these, when you evaluate a patient, first thing you want to see whether the patient is fit or not. okay, whether the cornea is good or not for laser surgery. Second thing, then you start planning. Now with these scanners, what we have something called as foresight. If you look at that, foresight is something you can dry run your treatment, right? Not in the surgical table, but you can plan. So it will tell you your post-operative corneal scans, your post-operative K readings, can tell you your post-operative corneal thickness, and also your post-operative higher order aberrations, and also the amount of treatment that is happening in the scans. So this is an amazing, and we've already gone into version 2 version, and the third version will be out at the ESCR. So what is it is, especially for your keratoconic patient, normal patients are usually very easy. But for the keratoconic patients, foresight will tell you everything. Sometimes we think, oh, we are doing good things over here, but then foresight will tell you that you're doing a wrong thing. It's an amazing thing with these devices, and then you can treat directly. So customize is something that you have to understand, that the anterior surface of the cornea and the posterior surface of the cornea are not the same. So if you're doing a wavefront treatment on the anterior surface, which could be like this, and your posterior surface could be like this. So, so sometimes you do a wavefront treatment and then you land up with another bigger problem. So these scanners are so smart. The total corneal aberration can be seen, and then the laser is also very smart. So customized means everybody has different refractive errors. We have different higher order aberrations, and they can be treated like any of your custom-made design clothes. So this is your foresight. So what foresight is, you can put in your scan over there. So you can put in your scan over there, and you can choose any of the profiles, and it will tell you. You can see what your post-operative cornea will look like, what your higher order aberrations will look like, what your KVDs will look like, what your corneal thickness would be, and what everything post-op, what your pachymetry would be, and also what your post-operative refractive error will be. You can tell your patient, this is what your vision will be like, this is what your power will be like, and the patient will be so amazingly thrilled to say, oh, the doctor knows everything what my post, because this is more than AI. This is on the dot treatment all the time. And now let me go to the femtosecond laser. A little bit I've talked on the ATOS and the the MRS and the scanners. So this is something which I really love now, okay? The ATOS femtosecond laser, it is one of the most intelligent femtosecond laser. Few of the things we'll be talking about is how it is intelligent on low doses, tissue saving, quasi-telecentric optics, and all the reads, and what are the other things it can do. What I really want to start over time when I was with the Zeiss, I was always fighting. One thing that I really wanted was eye tracking. So with the VisuMax 500, we never got an eye tracking. We used to assume, okay, we are there. In fact, Dr. Devgan is here, let me tell you, the FDA trials for the VisuMax for SMILE, the data were taken from my clinic. That was back in 2015 by Guy Curzin. He came with a big team, FDA team, and then this is started. And I was already doing the hyperopic clinical trial also then, but they always had an issue that was, how do you know it is on the visual axis? You think you're on the visual axis, you're not on the visual axis. Okay, so this is the biggest problem with the VisuMax 500. That's when we started developing a laser with the ATOS. We wanted it to be on the dot, perfectly on the vertex. One. Secondly, every time we had a users meeting, we were always talking about lenticule tears. So that is one thing. Thirdly, after surgery, the patient would be, nobody ever had the guts to do SMILE in one eye and LASIK on the other eye, because the patient would immediately say, oh, my vision in the SMILE eye is not good. Doctor, when will my vision come back? Like, you do SMILE in both eyes, and at the end of the surgery, you see, oh, you're seeing 20/20, very good, this, and just before leaving, they'll say, doctor, when will my vision come back? Even when they're seeing 20/20. So this is the amount of swelling they had, okay? And we were working on that. So now we have the latest thing, for 1.5 years, we have what is called as NOVA. We wanted perfect centration. So what is NOVA? SmartSight NOVA is an advanced lenticular extraction procedure using the new Centrex technology. Centrex is an active, intelligent centration and compensation system. It recognizes the pupil movement during and the last stages of docking. It enables an improved and optimized centration of the eye, that is smart docking, actively compensates the residual docking error. Okay, I will explain to you. This line is the most important. The compensation for the residual docking error. Centrex profiles were used developing, considering lateral and torsional fixation errors using asymmetric transition zones, lead to symmetric profiles with symmetrical optical zones and asymmetric transition zones. So now what it is doing is the laser recognizes all the images from the scan. It knows where the vertex is. It knows the amount of cyclotorsion that has happened. But when you dock, now when you didn't know with the 500, you are docking somewhere nearby. But when you can see, okay, the vertex is there, you want to dock perfectly on the vertex. So, but when the patient is squeezing or there's cyclotorsion, it's not possible. So when you redock and you redock and you redock, so what happens is the eye becomes soft, fluid gets in, you get black spots, the dissection is not possible. You can get subconjunctival hemorrhages. So what NOVA did was, even if you have a docking error, it can re-center the optical zone of the lenticule. It can take the lenticule and go right onto the visual axis. The edge of that centration, that the transition zone, which is a huge, huge transition zone, becomes large. The transition zone becomes asymmetric. The optical zone is symmetric, nice and round, but the transition zone becomes asymmetric. It becomes smaller on one side and large on the other. That the optical zone is concentric to the determined treatment center and within the transition zone, so that if the transition doesn't become small, it will go outside the cap. Okay, so this is very important. That the transition zone of the correction is an off-center crescent relative to the treatment center and the crescent to the axis. What it's trying to tell you is the whole thing is perfectly aligned. You have the cap, you have the optical center that has been decentered, but the whole treatment is within the cap itself. So the method provides a reliable and objective way to recenter the optical zone of the lenticule in the presence of lateral and torsional fixation errors. So no matter where you dock, the laser will smartly go and put the lenticule right on the visual axis. This is like a very, very smart thing to do because it is always not perfect. The shape of the lenticule is also very different. It is thick in the center, thin in the periphery, and has a large transition zone about 0.8 millimeters. But you have to understand that the lenticule is also not parallel to the surface of the cornea, but it is a little steeper. So you tend to save a lot of tissue over here. It is very good for high myopes, but also on the low myopes, sometimes you might have to increase the optical zone size so that it doesn't become too thin. The laser itself is a high frequency laser, 4 megahertz, very, very, very fast, with an excellent numerical aperture. The numerical aperture, the larger it becomes, the resolution becomes better and better. Why is it important? And the second thing over here is the quasi-telecentric optic. So it is a spinning scanner that goes right down near the cornea and is always firing perpendicular to the cornea, not firing from one point. So there is no deflection in the periphery. So what's happening over here is that the cutting quality is the same in the center as well as in the periphery. So it becomes very, very easy in the center. There are no lenticule tears or anything like that. So this is one very important. And another thing for the high numerical aperture and the quasi-telecentric optic is you can reduce the threshold. That is, you can go down to 50 nanojoules, reducing the pulse energy. But just reducing the pulse energy is not enough. We had perfect centration. We had everything, cyclotorsion component, everything was happening. We also reduced the pulse energy, but what was not happening was we weren't getting the best results. Then we realized there is something else over here besides Besides the pulse energy, there's something called as dose. Like when you do phaco, like you can have low phaco power, but if you do cataract surgery for more than 40-45 minutes, the whole cornea will be very swollen. Similarly, you can have low pulse energy, but the amount of energy that is going into the cornea can be very high. Then we realize that the dose is the pulse energy divided by the spot distance divided by track distance multiplied by 100. That is the amount of energy that is going into the cornea. Sometimes can be very high. So if you can reduce the pulse and you have a spot and a track distance of 2 and 1, you can still have a lot of energy, that's 2,500. So it can really make the cornea swell a lot compared to, you can make the pulse energy higher, but playing around with the spot and the track distance, you can really make the amount of energy very low on the Atos. So immediately after that, we did a little bit of trials over here and our results are amazingly good. So back in 2022, like you said, 22 is many years ago, we were still struggling to get 20/20 vision in 1 week. But now, in day one, 92% of our patients had 20/20 day one. If you look at that, 62% of the patients gained 1 line, 63% of the patients 20/16, and 1% gained 2 lines in 1 month. And if you look at the scatter, they are really tight. And we've also done 90 eyes for 3 months. They are amazingly good, actually. Most of them are within 0.5 diopters. 86% of the eyes treated achieved uncorrected visual acuity of 20/16, gaining lines from the pre-operative corrected distant visual acuity in 3 months. So these are amazing results. So now I can do easily SmartSight Nova on one eye and then LASIK on the other eye. Very easy. Patients don't even realize. And the stability part, I use a nomogram. So the nomogram makes it, I overcorrect a little bit because of the epithelial remodeling that happens after surgery, because once you flatten, there's going to be a remodeling. And after 1 week, most of the treatments are very stable. And even for astigmatism, this is amazingly good because you're perfectly centered, you have very low corneal swelling, you don't induce any amount of astigmatism, there is no coma or there is no other aberrations that the patients are very happy from day one itself. So just to say, it is very safe, results are very good, and I'm very happy with Atos, and Turkey has 5 Atos now, and I think some more are coming. And I think it is an amazing tool to do most of it. You can also do a femto trans PRK with the Atos. So in one of my clinics, I have only an Atos. So even if I get a suction loss, I can do a PRK, a trans PRK, with the femtosecond laser itself. And with the advent of foresight, most of the lenticles now you can do are customized lenticles. You can play around because they are perfectly centered now. The swelling is little, and then you can play around. You can induce negative spherical aberration or some amount of aberrations. And now the next event would be to have Press VMAX lenticles, probably at 2027 ESCRS. We are already doing mixed astigmatism treatments. So the laser point, you have the MRS, amazingly good. Most of people know about it. The Atos, they are great lasers with SmartSight Nova and SmartSight. They're actually 2 different things. SmartSight and SmartSight Nova with large flaps, with tissue saving, and amazing diagnostic devices. So on the clinical benefit, patients are very happy. Its recovery is very fast. On the economic benefit, patients, they get more referrals coming back to you. Happy patients send you more patients. And I think this is what I have to say. And a little bit on the Press VMAX. I don't want to go on and on because it's almost 10-15 now. The Press VMAX is something like the EDOF thing. What we really have to understand is what we are doing with EDOF, inducing negative spherical aberration. So even in cataract surgery, sometimes you put an EDOF lens, patients are very happy. Sometimes they are not, because we are not looking at the spherical aberration before surgery. So I just had Press VMAX surgery about 9 months back by one of my friends, David Kang. So I had the monocular version because I was absolutely good on my left eye. So what it does is inducing negative spherical aberration. So micromonovision, what it does, it gives you a good depth of focus in both your eyes, in your right eye as well as your left eye. And then I use them mainly for people who are in offices most of the time. So the most famous one is the hybrid. In the right eye, you give a little bit of depth of focus, and in the left eye, you give a lot of depth of focus. And in the Presimax monocular, the right eye is mainly for distance, and the left eye, you have a lot of depth of focus, but they blend in very, very well. So the most common is the hybrid. There are a lot of things you cannot just start doing it. Like if you know how to do LASIK, doesn't mean you can do Presimax because you need a training. So one of my friends just had a training today. So there are other things that come into play. The pupil size is just the opposite of what we usually understand, because if the pupil becomes small, it becomes more myopic and your near vision gets better. So in broad daylight, you might need sunglasses because your distant vision becomes a little blurry. And for dim light, you might need bright illumination for your reading. So this is all I have to tell actually, not too much. Let me not bore you down to that before your dinner time. But Presimax is something that you need a lot of time now. The chair time, especially you counsel your patient a lot. You cannot just tell it, okay, we'll do this. You need to do a contact lens trial. You need to do, patient has to walk around. You have to counsel them. And you have to also tell them that you might need a retreatment. Sometimes you retreat only the spherical part, or sometimes you treat only with the aberration part, the spherical aberration part. And sometimes you might want to redo the whole thing. The patient is so unhappy, you can also do reverse the whole thing, Presimax. I just did my sister about 3 months back, and she's absolutely happy. Presimax. What I usually do in my clinic nowadays is I do Atos SmartSight and a LASIK Presimax monocular on the left eye. So most of my patients are very happy. Thank you so much. I know it was a long thing. With the MRIs and the Atos and all the scanners and the Presimax and all I tried to remove many of the slides. And I hope many of you get into refractive surgery also, besides the cataract. Okay, thank you so much.
Evet. Teşekkür ederiz Doktor Kishore, bu güzel konuşma